Hello everyone, welcome to the weekly Mind the Bleep webinar. Today we have a very exciting session which is part of a series of Prepare for an F1. We're going to be talking about well-being and welfare advice today, and we'll be joined by the representatives from the MDU as well as the BMA. So it's going to be a very exciting session. We're joined by Dr. Fryar, Daniel Tyler, Lausanne Stevenson and Clare James. And the session is going to be run by Janhvi Shah. Just a brief introduction before we start. Please remember to sign up for the weekly webinars at the mindthebleep.com/webinar registration. I'm going to post the link in the chat section. All of the materials are going to be recorded. So please sign up to make sure you don't miss the future sessions, as well as ensure you get access to this presentation. Before we start, just a quick shout out to our sponsor, the MDU. Please don't forget to sign up for the MDU Foundation membership before you start your shadowing, because unless you filled in a foundation application form, your student membership will cease to exist in the summer. So it's essential that you have indemnity cover. So please check out MDU, sign up for the link. I'm going to include the link in a comment as well. And now, without further ado, I'm going to hand over to Dr. Janhvi Shah, who's going to run the session on welfare and well-being. I hope everyone is going to enjoy it.
Hi, thanks Zara for that wonderful introduction. So my name's Janhvi and we're joined by Akash as well from the Mind the Bleep team. So we're going to be running the webinar on welfare and well-being today. We're really fortunate to be joined by both the BMA and MDU. And it's rare that you get the wonderful opportunity to have both of them at the same time and ask all the questions you want. So please make sure you ask anything you want to on the chat, and we'll be sure to reply to it right at the end. So just quickly, what we're going to cover today. So we're going to start with the MDU, covering medico-legal support when things go wrong or might. Then we're going to move on to the BMA, talking about well-being, burnout, and services to health. And then finally, we're going to end with dealing with difficult colleagues and bullying, and information on Rotor and maximum hours that can be worked. So without further ado, I'll pass it over to the MDU. So if you want to share your screen, and we'll get started. Thank you.
Okay, it says I can't share my screen while someone else is sharing, so I don't know if the other person can stop sharing, and then hopefully I can now share my screen. Yeah.
I have now enabled multiple people to share, so that should be okay.
Perfect, lovely. And I'll just check that everybody can see my slides. Yeah. Okay, so welcome to this evening. I'm Dr. Caroline Fryar. I head up the advisory team here at the MDU. So we're going to cover support when things go wrong or might. I would say at the outset that although we're talking about when things go wrong, actually, ideally you seek support before they do, preemptively. And just by way of an understanding as to what that might look like, I'll just fill you in as to who we are. So my team comprises mainly doctors, and there are over 40 of us. We range in specialities. I'm a GP by background, but I have anaesthetists, neurosurgeons, diabetologists, endocrinologists, you name it. We tend to have people from most specialties. And we're spread all over the UK, which means that we can get out and support you when you need it locally at your trust. And indeed, we work very closely with the BMA in doing that. In terms of what we do, we have over 20,000 calls a year to our medico-legal advice line, and we open about 10,000 new cases a year. And as I say, we prefer proactive, we prefer to help you before it's a problem. And this just gives you a breakdown of calls to our advice line in the last 12 months. I've run it to October 20 because if we run exactly the last year, COVID is basically the flavour that you get. And just to give you a slightly broader understanding of the normal range of things we get, this is a mixed range. But you'll see that general advice is our most common thing. what does that look like? Well, it's always tricky. There are so many different things that we're contacted about, but by far the most tricky ones fall into these common themes of confidentiality and consent. Complaints are, of course, our bread and butter, and certainly after ethical medico-legal queries, the most common. But in terms of proactive things, these are what we see. Public interest disclosures, so the police turn up at your hospital wanting information about a patient that you've seen. Can you give that information? Obviously, doctor-patient relationships are confidential, but there are occasions when you can breach that. So that's one of the common queries we deal with. And also requests for access to medical records. One of my staff has just been dealing with a complex issue today in terms of the police wanting access to somebody's medical records, and these are rarely straightforward. Often the requests span not only the patient but perhaps their relatives as well. So that's a common sort of thing we deal with. The most common reason that I get woken up in the middle of the night, and I don't often get woken up in the middle of the night on call anymore, those days are happily gone, but when we do, it tends to be to do with issues in treating patients who are lacking capacity, or particularly patients in the emergency departments who've taken an overdose and have questionable capacity and are refusing treatment. So those are the sorts of things that we're there for. But what I would say is over the last year or so, I think we've found that anybody we speak to is just more stressed than normal, and that's entirely understandable. But anybody who gets involved with any sort of medical legal issue is effectively the tipping point. There's so much going on already, and that additional stress is just too much. So we're finding that so many of our members are really struggling and needing a lot of support. And in terms of our support, clearly the bulk of that falls when things do go wrong. So this is a fictional case example of something that has gone wrong. We've seen many cases like this. This is not unique. But if you imagine that you're the F2 in this occasion, and you're looking after a lady who's post-elective hip replacement, a known diabetic, and the nurses are concerned that she sounds chesty and has low O2 sats. You go to see her, and you think it's probably a chest infection, could be heart failure. I'm sure you'll all be familiar with that sort of difficult decision between the two, or if not now, certainly give it 2 or 3 months and working on the wards, you will be. So the F2 arranges some bloods and a chest x-ray, and then it's a question of, well, what actually to do, and rushes off the consultants in clinic, so finds the consultant in between patients in clinic, has a quick discussion and follows the request of the consultant for those IV antibiotics, quickly prescribes those on the ward whilst bearing in mind lots of other things to do, lots of other patients to see, rushes off to deal with another call about a patient who's on another ward, unstable blood pressure, clearly urgent. On that other ward, they hear the arrest bleep go out to the ward they were just on. Initially think nothing of it, and then of course the horror of horrors. This is the patient that you just prescribed those antibiotics to a few moments ago, and they're contraindicated, there's an allergy. Whenever I talk to people about this, a lot of people will say, well, of course that won't happen. The allergy will be written in the notes, the patient will tell you they're allergic. The drug codex will say there's an allergy. They may well even have a marking about the allergy on their bracelet. Absolutely, all of these things are there, and they're there for good reason, to try to prevent these things from happening. But these things do still happen. Not as often as they did, but they do still happen. And really what this case is about is illustrating the range of things that can happen in terms of investigations once you're involved in a clinical incident. And to my mind, these are the things I would have perhaps wanted to know about when I was at your stage, because knowing that they might happen means that you can put yourself in the best position to deal with them or to preempt them if they do. So I'll just give you a little few of my top tips in terms of what we can do by way of support, or what you can do if something goes wrong. So first things first, in terms of claims, they are indemnified by the NHS at the stage that you're working at, but you would become involved in a claims process in terms of giving statements, reviewing expert witness evidence. The issue with claims is they can be brought a very long time after the incident, at least 3 years in normal terms after the date of the incident, but for children it's up until their 21st birthday. For adults lacking capacity, there is no time limit. So what this really means is, well, can you really remember that patient that you saw on the ward 3 weeks ago? Exactly what you did, exactly why you did it? Probably not, given how many you're seeing. So really the thing about claims is making sure that you make good notes. If you haven't realised this already, any talk from the Medical Defence Organisation will always refer to the need to write good records. And okay, fine, seems obvious. And I suppose in an ideal world, you'd write reams and reams and reams and that would be fine. But you're not working under that situation. You have got a pressure of time. So good notes really mean making sure you've got the salient features. Who was there? What was your working diagnosis? What were the red flag symptoms? Or more relevantly, what weren't the red flag symptoms? What was missing? If somebody has chest pain, have you excluded the causes of a DVT, and do your notes show that? So some relevant red flags, but also safety netting or a plan, and making sure that plan is followed out, be it do some blood tests, chest x-ray, whatever, but make sure there's a plan to actually follow that up. And if you're finishing shift, make sure that you hand that over to your colleagues. The next one, the criminal investigation. Now, the case I've just given you the example of is ripe for criminal investigation for gross negligence manslaughter. The issue with that is twofold. One, it's incredibly stressful to be called to the police station and have to give an interview under caution. But two, even if it doesn't progress, it can drag on for a huge amount of time. And that hanging over you is so very, very difficult when you're trying to progress your normal day-to-day job. So the only top tip I can give you on criminal investigation is call your MDO. Don't attend any sort of police interview without us. That is what we're there for. But it's a much lower level, because most incidents don't run the risk of criminal investigation, and I don't want to scare you all. But thinking about it at a lower level, if I'm the medical director faced with the scenario we've just discussed, my role on behalf of the trust is to make sure that you are safe to continue working. And that really comes down to your level of insight. Somebody who says, well, it wasn't my fault, it was the consultant's fault, they gave me the wrong idea for the antibiotics. It was the nurse's fault because they didn't check properly. It was the rotor's fault because I was being pulled in too many different directions. Absolutely, all of these things are valid, but to blame everybody else but yourself means that your insight is probably somewhat lacking. And I, as the medical director, am then quite concerned as to whether I can have this doctor continuing to work whilst the investigation goes on. So it's important to try to show insight when you've been involved in an adverse incident at any level. And the sorts of things can be personal reflection, thinking about your own knowledge base. Are there gaps? Can you change that? Are there protocols in the hospital that could be changed to the benefit of everybody? Is it worth presenting this case anonymously to colleagues so they can also learn from the same areas? Is there any online learning you can do, modules you can do, certificates you can get to show that you've done your reflection, that you have insight into this? And the reason reflection is so important links to the GMC as well. The GMC doesn't investigate a huge number of cases, but those that it does, in terms of their ability from stopping you practicing, it's incredibly stressful. And what the GMC is looking at is your ability to reflect and your fitness to practice today. So if this adverse incident had happened today, it may not reach the GMC for a number of months or possibly a year or so. In the meantime, you've got that opportunity to learn and reflect, and that is what will stand you in good stead at the GMC. As an organisation, it does accept that things will go wrong, but it's how you deal with those that puts you in the absolute best position. Complaints, what do patients want? Well, an apology, an explanation, and a reassurance it's not going to happen again. How do you do that? Well, if you've done the things we've talked about by way of reflection, insight, you can help on that reassurance it's not going to happen again. And the openness and the apology, you don't need to wait for the complaint. If something goes wrong, you can apologise. It's not an admission of liability. So if you feel that you would apologise in the same way that if you bump into somebody when you're walking along the street, you'd say sorry. If your natural reaction when faced with an incident is to say sorry. Don't be afraid of that. But we can help you in terms of wording complaint responses to stop you from admitting some form of liability when you're saying sorry more formally. Inquests, really common, much more common now than they were, becoming more adversarial, although they're not supposed to be. But coroners' officers do tend to quiz families on whether they have any concerns about the treatment that's being provided, and so that does tend to raise the stakes somewhat. From the point of the view of the inquest, the best thing to do is all about the statement. It's making sure that you do one statement and you do it once and you get it right. So if you're ever asked for a statement about your involvement in anything, and not even just the death of a patient, but much more minor things, anything at all, don't be tempted to just trot out a few lines by way of email after your end of your night shift. Take some time and get some advice. That is what we're here for. And in terms of support, I think it's one of the most important things we can offer for you, because if you put something out that isn't quite right or is going to get yourself into difficulty, it's very, very difficult to go back from that. We can always offer supplementary information, but you can't really get away from what you said at the outset. So do it once and get it right. And we've done tens of thousands of these, so we can help you. CQC, just a minor nod, that's more of an issue for the trust, but suffice to say, if they end up with difficulties to do with breach notifications, something having gone wrong and you're involved, they're not going to be delighted. So again, important to work with the trust and do what you can to avoid that. And media attention, I think you all know that it goes without saying, the newspapers love a good story about the doctor doing something wrong. You see it in there day in, day out. Awful, and just has to be left, and hopefully the story loses interest in a day or two. But we do have a press office, and that's what they're there to help support you. So just in summary, those are the top tips as to what you might do. But I think the most important thing I would say about support when things go wrong is support one another. Don't be afraid to talk to your colleagues and your friends and family. You needn't give, obviously, identifiable information about patients, but in general terms, talk to people about what's happened and why you're feeling like that. We've had many cases over the years where people haven't been able to do that. Even people who've been suspended from work but not able to tell their families and still left the house at 6:30 every morning and returned at 7 p.m. each night as if they've been at work, but they haven't. And that is an awful situation to be in. So nobody wants to get involved in an adverse incident, but if you are, be brave and raise your head above the parapet and talk to your friends about it, about how you're feeling, because you won't find them saying, oh goodness, well, I can't believe you did that. How on earth did that happen? Far from it. They will be supportive. And as time goes on, if you're talking to more senior colleagues, they will have been there, done it, experienced it all. But we're there 24 hours a day, every day of the year. We do have as well, uniquely amongst all the MDOs, a peer support network, which allows you to have the opportunity to speak to another MDU member who has been there and done that, got the t-shirts. And so we find that's really helpful, and it's not there, that's not about the nuances of the case and the specific running of it. That's what my advisors are for. This is about how these people coped, where they sought support, the best things to do to try and put things to the back of your mind when they're dragging on. And I've put a link here, if you go on our website, to other sources of support, and I know, and the BMA is indeed one of those areas we point to. We do also have, just to finally add, because I know I'm at 20 past, so bang on time, we do have an online wellbeing module. So you might want to access that. I can probably try and put the link to it in the chat whilst the BMA are speaking, but that's based on our experience of sort of stress and burnout, and you know, the people who've done it have found it very helpful. So there are lots of areas of support out there, but the first thing to do is ask, and don't wait until something goes wrong. I'm going to finish there. I think we're going to do questions at the end, but I hope you found that helpful. Thank you.
Perfect. Thank you so much, Dr. Fryar. That was so useful, and it's really good to know the support networks that are available. I think we'll pass over to the BMA now, so if they want to share their screen, and we'll continue with that. Any questions to Dr. Fryar, just pop it in the Facebook chat, and we'll be sure to answer them all at the end.
Sorry, I was just being a bit slow on my screen. Can you see that okay?
Yes, but we can also see your notes. So
you'll see my notes. Okay, bear with me for a second. Thank you. Sorry, this is shared the wrong screen. Not used to Zoom. Sorry, I'm normally on Teams. Let's try that. Can you see the right screen now?
Yes. Can you?
Perfect. Thank you very much.
Second slide just for a sec to see if we're not going to see your notes, because sometimes that's the case.
No, it looks good. It looks good.
Looks good. All right, that's perfect. Okay.
Great. Okay. Thank you. So hi, everybody. My name's Clare James, and I work in the Wellbeing Support Department at the British Medical Association, helping with the day-to-day running of the wellbeing support services that we provide doctors and medical students. And I'll talk a little bit more about those later. So first thing I need to say is that I'm not a doctor, so I can't pretend to know everything about being one or the wellbeing challenges that you're facing, but I have been working in this role for 2.5 years and have learned quite a lot about doctors' wellbeing during that time. And I've been asked to come along today to talk about doctors' wellbeing, but specifically about burnout. So I'll start by briefly setting some context of doctors' wellbeing, but I'll focus on burnout, what it is, the science, how to prevent it, what to do if you think you're struggling with it, and so on. And then I'll end by talking very briefly about the services that the BMA provide and some other sources of support as well. So just to very briefly give you some insight, doctors' wellbeing was facing a huge problem before the pandemic hit. As you can see on that slide, back in 2018, 2019, the BMA did a big mental health survey and thousands of doctors responded. And of those, 80% of them reported that they were at very high or high risk of burnout. Then throughout the pandemic, the BMA have been running monthly tracker surveys, and in our February tracker survey, just over 40% of our respondents said that they're currently suffering from any of depression, anxiety, stress, burnout, emotional distress, or other mental health conditions related to or have been made worse by your work and studies. So what exactly is burnout? So the World Health Organization defines burnout as a syndrome conceptualized as resulting from chronic workplace stress that has not been successfully managed. And they characterize it by 3 dimensions. So feelings of energy depletion or exhaustion. So by that they mean emotional exhaustion, that feeling of unable to, being able to give anymore. Increased mental distance from one's job, or feelings of negativism or cynicism related to one's job. So depersonalization, and not in the usual psychiatric sense, but instead they mean by sort of cynical attitudes towards your patients and colleagues. And then lastly, reduced professional efficacy, so lack of feeling of personal accomplishment and a tendency to evaluate one's work negatively. There are so many causes and contributing factors for burnout, especially for doctors. The statistics that you're seeing on the screen in front of you are from a Medscape UK survey last year. And at the top of their list from that survey, I think that was about 2,000 people had responded. The top contributor for burnout for those respondents was a lack of respect from administrators, employers, colleagues, staff, and so on. And we know that there's evidence from the Civility Saves Lives movement that incivility can affect the person on the receiving end by causing 61% less cognitive ability, but it also impacts anybody that witnesses that incivility as well, and they result in 20% less cognitive ability. And I'll link to that research at the end. In a parliamentary report that was published last month on workforce burnout and resilience in the NHS and social care, the authors concluded that chronic excess workload is a key cause of burnout in doctors and that better workforce planning is required. I'm sure that for all of you that won't come as a surprise. It certainly wasn't a shock to me. Dr. Dyke Drummond, who's also known as the Happy MD, he has identified an additional 5 main causes of burnout in doctors. Number 1 being the energy it requires to be a doctor. So if you think about what you have to do every day and dealing with that stress and the distress and suffering and death every day, and that's without the pandemic to contend with, all of that takes a lot of energy to cope with it every day. The conditions of your particular job, as we know from the parliamentary report that I just mentioned, chronic excess workload is the biggest contributor to burnout. But it's not just about the pressure, it's also about the workforce and how you're all working together. And if you're not working well together, then that can contribute towards burnout as well. Your home life can be a cause of burnout, or at least contribute to it. If you're not finding your home life relaxing, or you're not having that time to recharge when you're not at work, that can contribute to burnout as well. The leadership qualities of your boss or supervisor. So you may have heard about compassionate leadership, particularly over the past year. And we know that compassionate leadership is linked with psychological safety of staff, so that you feel able to speak up. And from those compassionate leaders, it means they're paying real attention to their staff, really listening, really trying to understand the challenges they're facing rather than imposing some kind of understanding. And then lastly, the programming of your medical education. So if you think about medical school and personality traits such as perfectionism that come with naturally come with people who train to be doctors. And then this sense through medical school that's drummed into you that you should be able to cope in these situations and you should be invincible like superheroes. And all of these things contribute towards your identity as a doctor. And the same Clare James wrote in her book Beneath the White Coat, which was published last year. She regaled something a patient once told her, which is that a doctor is something you are, not something you do. And all of these things can contribute to you feeling burnout. And then lastly, just wanted to highlight this emotional energy matrix. You may have come across it before. There's a really brilliant webinar that I watched last week from Dr. Michael Davey, and that's where this has come from. This is his summary of the matrix. So essentially, I haven't got time in my talk to go through it all in detail, but I'll link to his webinar at the end so you can watch it when you have time. Really good. But essentially he's saying that so if you've got the energy levels in the middle and then your emotions on the horizontal line, and he is suggesting that we all need to spend all of our time on that right hand column, so thriving and reviving. You need that time to revive to be able to continue to thrive. If you spend too much time thriving, you're going to find yourself surviving in that top left corner, sorry. But if you find yourself surviving for too long, then you're going to end up burning out if you're not getting that time to revive. That can lead towards burnout as well. Excuse me. So some of the signs for burnout. Some of you might have been able to read the text that was with my previous slide, but I'll make sure that I get this sent to Mind the Bleep afterwards so that they can send it to you so you can see it more clearly. But these signs are from very well mind. The alienation from work-related activities. So you might be starting to view your job as increasingly stressful and frustrating. You might be growing cynical about your working conditions or the people that you work with. You might be finding yourself emotionally distancing yourself from your work or beginning to feel numb about your work. Physical symptoms can happen if you're starting to burn out. We know chronic stress can lead to physical symptoms such as headaches, stomach aches, intestinal issues, increased heart rate, and so on. Emotional exhaustion, so you might be feeling drained, unable to cope, you might be feeling tired, and you might be lacking the energy to get your work done. And lastly, reduced performance. So you might be finding that your everyday tasks are taking you longer than they normally would. You might be feeling negative about doing certain tasks. You might be having difficulty concentrating. You may find that you're lacking creativity and unable to think out of the box and problem solve and so on. And some of you may be aware that some of these symptoms are quite similar to depression and other mental illnesses. So it's important to remember that with burnout, we're specifically thinking about what relates to your work life and not all aspects of your life. But there is a survey on the BMA website, which can see how risky you are of burnout, which you fill it out and it's for your eyes only. We don't see any data from that. And again, I'll link to it at the end. In terms of preventing burnouts, Dr. Dyke Drummond again has put together this burnout prevention matrix, which Dr. Kate Little, who runs the Physician Burnout website, has summarized as: reduce your stress at work, reduce your stress at home, increase your ability to recharge at work, and increase your ability to recharge at home. And I know so that some of those things are going to be quite difficult to do. But at work, for example, you could try and recharge at work. If, for example, your hospital has a wobble room, I know that quite a few have introduced these over the last year and a half, just a space for you to just escape the chaos of the wards for a few moments and just regroup a little bit and just have a breather. Or talk to your colleagues if you feel comfortable doing so, and increasing your ability to recharge at home. Just try and make sure that you're carving out time for you as well. I know it's really easy to get caught up in chores and home life and looking after the children if you have them and all of these things, but just it's really important as well to have some time for yourself too. So what to do if you are feeling burnt out? So if through listening to this, or even before you came to this talk, if you're thinking that some of it resonates and you're starting to think that maybe you are feeling burnt out, or you just want to know future reference, it's really important that you recognise that you're feeling that way and seek support early. There's loads of support out there. Most trusts now have some kind of support, but as I say, I'll signpost to some as well towards the end of my presentation. As we saw in the emotional energy matrix, you need time to revive. So really do make sure that you're finding that time to rest and recover and allow yourself to do that. It's really important. And then make sure you're doing activities that are completely different to your work day. So if you are finding that you're glued to a screen, for example, then make sure that when you do finish work that you're getting out in nature, or you're going for a swim, or you're going out for dinner, or just something that isn't completely screen-based, just to try and give your brain that little bit of a break from what you've been doing all day. I appreciate that a lot of that will be completely out of your control. You might be thinking, well, I can't do any of that. So I thought that I might share this model with you as well. You might just find it helpful just to help manage feelings of uncertainty, help you manage your well-being a little better as well. So I have borrowed this from Dr. Lee David. She is the founder and director of 10minutesdbt.com and the mental health course director at Red Whale. And she's adapted it for healthcare workers from Russ Harris's The Happiness Trap, which is based on acceptance and commitment therapy. And she's adapted it as a way to face COVID-19. But as I say, I think it's applicable to face uncertainty as well. So I thought I'd share it with you. Hopefully you'll find it helpful. So F is for focus on what's in your control. So we can't control the pandemic or whether or not people are playing by the rules. We can't control the government's response. We can't control our own feelings to a certain extent, but what we can control is our own actions and our own behavior. So focus on what you can do rather than what you can't. A is for acknowledge what's inside. So take a moment and acknowledge your personal reaction to what's going on with something. And if you're able to put a label to that emotion, it can be really helpful into putting it into perspective, helping you understand yourself that little bit better and so on. That can just help you feel more able to cope with what's going on. C is for commit to a plan. So plan to actively do things that are important to you and choose actions based on what really matters to you. And that links really closely with E, which is engage with your values. And by that, we mean engage with your core values, so what you really care about. So that could be your family, your friends, fun, humor, professionalism, whatever it might be. Just make sure that whatever it is that's really important to you, you're finding time to engage with that in your life. And then just quickly, as I'm conscious I've got only a couple of minutes before I need to hand over to Daniel. I just thought I'd very briefly talk through the BMA services and then highlight another source of support that you might find helpful, and then I will hand it over to Daniel. The BMA's main support services are counselling and peer support, and these are free to any doctor or medical student across the UK. You do not have to be a member of the BMA to access them. Our counselling service is essentially what it says on the tin. It's counselling. You can get in the moment support, or you can get a structured course of counselling of up to 6 sessions, mainly over the phone or by video, but we have recently launched face-to-face, and our face-to-face network is increasing as the COVID restrictions start to lift and we get more COVID secure venues in place. And the counselling service is also available to partners and dependents aged 16 to 24 of doctors and medical students in the UK as well. And our peer support service is a confidential space to talk things through with another doctor. So it's not clinical, they can't diagnose you with anything, they can't prescribe you with anything, but what they can provide you is emotional support, so you can talk things through with somebody who's not necessarily immediately in your world, but understands your world. So it means that you've got somebody to talk to who kind of gets what it's like to be a doctor. And that support is ongoing. So some people feel better after one call, some people need much more than that, and that's fine, whatever works either way. And then Doc Health is our face-to-face confidential psychotherapy service that we run with the Royal Medical Benevolent Fund. Before the pandemic hit, all of our appointments were taking place at BMA House in London, with Skype appointments for people who were further afield or couldn't get to BMA House easily. But all of our appointments are taking place virtually at the moment. And like all of other services, you do not have to be a member of the BMA to access Doc Health, but unlike them, there is a fee attached. So for junior doctors, that's £65 per session, but there is financial assistance available if you need it. And then lastly, just wanted to highlight the Wellbeing page on the BMA website. It has got lots of different resources on there that you might find helpful, but I particularly wanted to highlight the sources of support page at the bottom there. There are lots of different resources on that page set out in finance, legal, counselling, mental health, and so on. And the majority of them are just purely for doctors and medical students. But at the top of that page, you'll also find a directory of wellbeing support services across the UK that are specifically for doctors and medical students. So you can click on your region and see what's available locally to you, as well as the UK-wide services. And then, as promised, I have linked to various burnout resources here, including the questionnaire that I mentioned that's on the BMA website, the webinar that I mentioned from Dr. Michael Davey, and the report as well from Parliament, in case anybody would like to give that a read. So thank you for listening. I'm aware that I've shared a lot of information, I've rattled through that, but I hope you found it useful anyway. I am also aware that there's a huge range of issues which can affect your well-being. So if you're looking for a particular type of support, but you're finding it difficult to locate, then please, by all means, contact us and we'll do our best to help signpost you. The main message I'd like to pass on along with all of this information is please reach out for help if you feel you might need it, and encourage your peers to do the same. It's really important. Thank you very much for listening. I'm now going to hand over to my colleague Daniel, who will talk to you through a little bit about what else the BMA can offer you. So thank you for listening, and I'll hang around at the end if anybody's got any questions. Thanks a lot. Bye.
Thanks, Claire. Sorry, you should be able to see my screen now, I think. Should be all good. So yeah, I'll rattle through my bit very quickly because I don't want to overrun. So yeah, thanks to Claire again for the talk. So I'm Dan. I'm just going to talk about BMA membership quickly. I'm sorry if you've heard me before over the different minded bleeps over the past few weeks, but at this time I come bearing a new gift, which is the offer that you see on the screen. So this is very rare that this comes around, but you can join the BMA now, and you won't pay anything until October. So that basically covers you through inductions and getting your contract, getting your rota. So use that QR code on the screen, or I've put the links in on the Facebook comments as well if you're watching on Facebook. So yeah, that QR code will also be in the top corner throughout the presentation. So if you're not a member, join, get it free until October, and then after October, hopefully you do stay on. But very, very pivotal time to be a member for sure. So yeah, so you probably all know this, but we're a leading trade union and professional association for doctors. So we act as the voice of you guys, representing you on an individual, local and national basis. So while it's your job it will be your job to look after patients, it's up to us to look after you. So we often get this, but we're not an indemnity company, so we do get confused at MDU sometimes. But we're not rivals. We're very much friends. So we don't deal with patient complaints. We are your union, so we're here to look after you, your working conditions, so things like pay, contracts. So we negotiate the contract that you're going on to, so we know what should be in it. Your professional development, and also, of course, your well-being with services like the ones that Claire's mentioned. So we understand the sort of things you might encounter, particularly when you become an F1. So we can give you advice and support on anything you might face. So it's going to be anything from relationships with senior staff to responsibilities that you don't quite feel comfortable with. So just keep us in mind. We can take any pressure off you if you're facing anything you need support with, and you'd rather not speak to anyone to trust about. We can come to us. We've seen most things before, and we've got relationships, and we've got people on the ground, every single trust in the UK, and we know the people in HR and elsewhere, so we can handle things for you. So yeah, I've briefly mentioned the contract checking service, but it's probably the key tool to use this year, this month, maybe ever, as being a member of the BMA. So it could potentially save you quite a bit of money. As I mentioned, we negotiated the contracts, so we know what should be in them. But sadly, 20% of the contracts we checked last year were wrong. So 1 in 5. So if you're a member of the BMA, you can get your contract sent to us. We'll check it in 5 working days, and if there's any issues, we can get in touch with the trust and get it rectified. Best to do this as quickly as possible so you don't have any issues down the line. If you've already signed it, that's fine. We can still check it. If it's wrong, it's wrong. And also, it's worth saying that we've also got a similar tool, the rotor checking tool. So with that one, you input your rotor and it'll flag up to us as wrong. But the rotor should be pretty standard. It's just the contract we do worry about. The 1 in 5 is just too high a number. So yeah, you also obviously, as part of being a member, you get the BMJ every week, so you get the doctor version now. If you're already a member and you're not getting the BMJ, the doctor version every week at the moment, just get in touch with us because we may have an old address for you. So yeah, you may be sick of learning now after finishing med school, but you've got access to all our clinical and non-clinical learning tools, as obviously you'll continue to learn throughout your career. So you have full access to BMJ Learning, which has over 1,000 clinical and non-clinical modules, and that's going to be really helpful when it comes to completing your e-portfolio. So BMA Library, thousands of ebooks and e-journals that you can access instantly from anywhere. And also we've got webinars that you can watch throughout the year and can be viewed on demand. And wrapping up very quickly, if you're thinking about your specialty options already, you can use our Specialty Explorer tool, which helps you get a bit of a better picture of what suits you best based on the answers that you give. So yeah, it takes about 20 minutes to complete, and it asks all sorts of work-life balance questions, and it'll give you a really personalized report according to the answer that you've given. So that's it from me. I'll wrap up. So again, if you're not a member, definitely join now. It's free until October. Get your contract checked, get your rotor checked, and just have peace of mind going through your year that everything's set and you won't have any issues further down the line. That is it. Very whistle stop from me.
Perfect. Thank you, Dan and Claire. That was really useful. I'm going to quickly move on to my bit, but at the end of all of this, everyone's going to be around for questions. So please, everyone, let me just check this works. Please, everyone, put all your questions and comments in the Facebook comment section, and we'll be sure to answer them at the end. So I'm going to talk today about dealing with difficult colleagues and bullying, which unfortunately is still quite a common thing that we come across, which I'm sure the MDU and BMA will back me on. So why is it important? So there's a number of reasons. It takes an emotional and a professional toll on us. It's very challenging. And quite often we're not really sure how to deal with confrontation or there's a kind of a culture that F1s are at the bottom of the pile, and we need to change that and make it more acceptable to talk to everyone about this. It has a massive impact on your mental health. If you're having a bad time at work and you're dealing with difficult people, it can impact you professionally and personally, like I was saying earlier. And finally, not only does it impact you, but it also impacts patient care. A team that isn't working in an ideal way is of course going to impact how well a patient is looked after and the treatment of them. So just quickly, before we go on to some cases, I'm just going to go through these different styles of communication. So if we look at this, first of all, whenever you're communicating with anyone, you need to think, how am I feeling and how are they feeling? Am I feeling okay? And do I think they're feeling okay? Are we communicating in an open and honest way? So aggressive communication is when everything goes your way. You get the job done, but of course you're not going to build relations like this, and you're making someone else potentially feel awful. Passive aggressive communication is kind of where no one gets what they want, and you're not getting it, and the person you're speaking to isn't getting it. The advantages of this are that there is no confrontation, but of course a team can't continue to work like this, and there are going to be problems further down the line. Submissive communication is when you don't get what you want, but someone else gets what they want. Now, of course, sometimes you do have to use this style of communication with certain aspects of medical care. But again, this should be avoided as it causes problems within the team. And finally, what we should all aim for is assertive communication. This is where everyone gets their point of view across and everyone feels good after the conversation that we've had. And now we're going to go through some cases to see how we can apply these things. So the first case, and if you have any thoughts on these cases, obviously put it in the comments section. The first case is something that's happened to me quite a few times. So a patient presents with abdominal pain and your consultant has requested an ultrasound scan. And unfortunately, the radiologist has rejected it. So what happens after this? Your consultant shouts at you for not getting the very urgent and important scan. Now, this can unfortunately happen quite often. And I think the first thing to think about is that you need to keep your emotions in check. Of course, this is upsetting, but you can't let it get to you. Also, we need to appreciate that the consultant and the radiologist are potentially going through their own issues. They could be having problems at work, at home, and we need to think about this as well. So how do we approach this? Of course, first of all, we need to say that this is completely inappropriate. No one should be shouting at you at work, and it's not fair if they do. This is a quote we got from an anonymous F1 saying, being an F1 is about being shouted at. Since I started as an F1, I've been shouted at every day. Now, this is rare, so don't worry, and it's just a one-off case, but this is, again, unacceptable. Even once is not okay, and we need to make it a culture that it's fine to raise our voices and say that we're not okay with this. So how do you approach this? The first advice we can give you is to speak in terms of feeling. So instead of saying you're being rude, you're being obstructive to me, you can say things like, when you speak to me like this, it makes me feel like I'm being dismissed. Are you aware of that? Now, if you talk in terms of your own feelings, no one can say that you're wrong. No one can say, no, that's not how you're feeling. And it's sometimes a good way to get your point across. If this doesn't work, of course, if you're feeling overwhelmed, then you can escalate, as we've heard from both the MDU and BMA. There are loads of places to go to. So first of all, your team, then your educational and your clinical supervisor, and then you can go even higher to the TPD, the Director of Medical Education, and like we said, the MDU and the BMA. So why is this important? Of course, this case in particular, even something similar to it, impacts patient safety and also increases burnout. So we need to make sure to tackle this early on rather than focusing on it later. As related to this, make sure you support each other. If you go through cases like this, talk to your colleagues. There's no need to do it in a rude way, of course. Don't need to blame people, but it's always good to talk about your experiences. Case number 2. So Mr. Andrews is an 86-year-old male who presents with hypoxia. You think this is pulmonary edema, but your registrar thinks it's sepsis and recommends IV fluids. Now, this is again something that happens quite often. And I think it's difficult when you're so junior to step up and say, oh no, I think I know the right answer. Of course, someone with years more experience than you, you would think they know it. But sometimes it's easy for them to miss it, or you could be in the wrong. But the main thing is, it matters that the patient gets the right care. Even if you're wrong, no one's going to get angry at you for saying, oh, what about this? Why don't we think about this? Now, if you feel uncomfortable saying it like that, we don't want to use, as we were talking about before, an aggressive communication style. So we recommend using something, an acronym called PACE. So first of all, start small, so probing. So just say, oh, why do you think this is a good idea? As in, can you explain it to me for my education? I would like to understand more about this. If that doesn't work, then we go to the next stage, which is alert. So this is telling them, oh, this is what the chest X-ray shows. Why would you go for this option rather than this? Still, you're keeping it nice and polite, but just making the registrar aware of what you're thinking. Next is challenge. So this is saying, no, please, I think this is the wrong thing to do. Can you think about something else? And of course, we don't want it to get to this point, but if it's a life or death situation, the final thing is emergency. This is actually putting your hand up and saying, stop, I don't think this is right. Please, can we discuss this further? Obviously, we want to stop it at about probe or alert. And most people, nearly everyone that I've come across, is happy for your education to explain to you why their way of thinking is this. And most actually senior doctors prefer if F1s do raise their voices. And it just brings a new viewpoint to the team, which is always a lot better than the same people talking about the same things. So key points from these cases that we've learned. So bullying and harassment should never, ever be tolerated. Be aware that there might be something else going on in people's lives. And finally, be very careful with your emotions. You don't want to come across as being either too angry or too upset. Try to keep your emotions in check, and then go afterwards to think about it, either with your colleagues, your friends and family, or all the support services that we've talked about today. Just very quickly, we're going to talk about information on break allowances and maximum working hours. Like Dan was saying earlier, it's rare now that there's a problem with your rota, but it's still worth checking. So the BMA, like we heard earlier, offers a rota checker. So if you're a BMA member, you can look at this and make sure that your rota is okay. For more specific rules, have a look at our article, because there's quite a few like nitpicky rules, and it's difficult to cover them all online, but we're happy to answer any questions, and I'm sure the BMA would be as well. So just briefly, we should be working less than 48 hours average, no more than 72 hours in any 7 days, no more than 4 long days or long nights. You should not be working more than 7 days in a row, and there should be a minimum of 11-hour gap between shifts. With breaks, this is of course very difficult, and unfortunately, it's not possible always to take a break. If there is a very unwell patient, you can't leave them. If you do desperately need to get away, then make sure you hand over to someone and don't leave everyone kind of high and dry. So you should have a 30-minute break in every 5 hours, 2 in every 9 hours, or 3 during a night shift. But like I said, just make sure you ask for them sensibly and don't pressurize people into that. If these rules aren't followed, then you must exception report. And this is key. Loads of people are scared to do it, but under the new contract, we are allowed. So please make sure you do. And I think that is it from me. So I think we'll go through some questions, but just before we do that, here's a link to our feedback. We'll be really grateful if you fill this out, because not only is it good for our portfolios and to know how we can improve, but also it's good for you so we know for future webinars what to do differently, and you'll get a certificate as well of attendance. So thank you to everyone. I'm just gonna pass it over to Akash to ask any questions that we may have.
Hi, so we have been sent quite a few questions in advance of this talk from people that wanted to attend but weren't able to. So I'm just going to go through those questions whilst we wait for some more questions to come up live on the video. So the first question is I think this is aimed at the MDU. At what point should we contact our defence union? If we contact too many times, does the indemnity cost go up?
Yeah, sure. I would say contact us as early as possible. No, the indemnity cost does not go up purely for seeking advice from us. It would be rather silly of us to do that, because we'd much prefer that we're involved early on, and we genuinely believe we have a positive impact in being involved. So discouraging members from contacting us only for them to get in further difficulties would be rather foolish. So it doesn't impact your indemnity costs, no.
Lovely, thank you so much. The next question is, I think, predominantly aimed at the MDU again. If I'm going through mental health issues or burnout, will people question my fitness to practice?
Yeah, that's a difficult one, because of course these things are on a spectrum. Obviously it's not for the MDU to question your fitness to practice, but we are involved in a number of health cases for doctors, either locally at their hospitals or at the GMC. I think the most important thing, if people are going through burnout, stress, difficulties, is to be open about that and seek the appropriate support and not concern themselves about fitness to practice issues that arise. And the reason I say that is actually the GMC is very supportive of doctors with health issues. It can't, for example, erase doctors, strike doctors off because they have health issues. It does occasionally interim suspend doctors if they are extremely unwell, but I'm talking about a very severe end of a spectrum. And that would have been done with advice of treating psychiatrists, for example. But for the normal sort of run-of-the-mill situations that people find themselves in, everybody is going to experience some difficulties and burnout issues at some point. They rarely hinge on fitness to practice, but if they do, it is a very supportive model with the GMC as opposed to punitive.
Lovely, thank you so much. The next question is aimed at the BMA, which is, what do the BMA counsellors help with? What are some common reasons that people would use them?
Sorry, I just had a sticky mic there. Really great question. The top reasons for that we get data from our help from the service every month, and the top reasons for accessing it are low mood, stress and anxiety, and what's the other one? Work related. Low mood, work related stress, and relationship issues are the top three that we see most regularly.
Lovely, thank you so much.
Oh, and there was a second part of that question, wasn't there, about what counsellors can help with? So pretty much, if you've got something that you want to talk about, they can talk you through it. And if it isn't something that they can help you with, they'll be able to help you get to somebody who can help you with it.
The next question is again aimed at the MDU. How common is it for cases or complaints to get resolved at a local level?
Yeah, very common, I would say. The vast majority are. I think the way we find that works is that, as I talked when I was talking about them being open and honest at the outset, apologising and recognising when things haven't gone perfectly, and trying to make changes. People want reassurance that things won't happen again. They've often something's happened, it's gone wrong, they accept that, but a lot of the time they complain, it's because they want to think it's not going to happen to somebody else. So if you can adopt as positive an attitude as is possible to a complaint, then the vast majority are resolved locally. Yeah, I don't have exact figures, but that's certainly my impression.
Lovely, thank you. I think the next question is aimed at both the BMA and MDU kind of at the same time, which is, what should you do if you are chronically short-staffed on the ward, and should you include this in your documentation?
Do you want me to go first since I'm unmuted? I think, should you include it in your documentation? I presume that means in the patient records. I'm not sure it's relevant to the care of the individual patient, and one has to bear in mind that the patient has access to their records, and so I don't see that that's necessarily the right place to put it. But should it be involved in documentation per se? Absolutely yes. If you have concerns about staffing, then you must raise those. Normally that's done with your line manager to begin with, your educational supervisor or your consultant. Usually you're not alone in those concerns, and so if your other colleagues share them, then getting together with them and putting the case forward can be helpful. Again, it's helpful to have specific examples, so rather than just we're short-staffed, some objective evidence, on this particular day, on this ward, I was the only doctor doing whatever. So some concrete evidence effectively that you can refer to. But yes, and I would suggest that is raised, as I say, jointly where possible and always in writing. So there is that evidence trail, but I just don't think it goes in the patient records. But I don't know what Claire would say on that.
I can come in. You can get in touch with the BMA. This is certainly something that we can get involved in. If you raise it with us, we can take it forward to the trust. you may not necessarily be brushed off, but if you'd like us to step in and talk to it, if it's something that's happening a little too often, and we can get involved. Like I said, we have industrial relations officers based at the trust, and this is really what they do day to day. This is the kind of issues that they can get involved in. So again, it's not being with the BMA isn't just about getting your contract check using the BMJ. It's issues like this that you can use us for. We have people that are here to handle those kind of issues.
Perfect. Yeah, so I would completely agree with the exact same sentiments that it's really important to raise. Again, I don't think the notes are the right place to put it. But there are lots of other avenues where you can raise it. You can let the Rotor coordinators or the service managers know about the short staffing on the ward. You can also raise it by an exception report. But I think the most important thing is make sure that there is some sort of trail saying that you did. Having a verbal discussion and just telling somebody, oh, by the way, we need a little bit more help today, doesn't quite cut it. And that it's quite important that you raise it not only for future patient safety, but also for yourself, because then you always have a trail saying, well, actually, I did raise the fact that there was understaffing on this particular day, and I was concerned that this would lead to potential issue. So that if an issue in the future does come to light, then at least you have a record to say, well, that was something that I was very worried about.
Certainly exception reporting, definitely a great start. It's exception report straight away, and then once we're involved, we have that trail as well, so we can say this hasn't just started now. This has been something that we hope hasn't been ignored, but if it has, then we've got a trail, like Akash said.
And I know that from my own experience, that exception reporting in chronic understaffing can be really frustrating, because you feel like you're almost exception reporting every day. But it's really important because it highlights an ongoing issue. But also you can get in touch with your Guardian of Safe Working, because they will ensure that you have that opportunity to basically voice exactly what's happening. So if it's an ongoing issue that's likely to continue to be ongoing, then raising it directly with your Guardian of Safe Working rather than waiting for them to during their quarterly reports, or when they're able to monitor the exception reports, going through that and then trying to infer what you meant by the details that you included. Contacting them in the first instance may get you that step quicker. Somebody's asked about feedback. We will be posting the feedback in the comments, the link in the comments also. But the QR code is up at the moment for you to be able to read it. The next question, I think, is predominantly again aimed at the MDU. I think many people are very worried about starting F1 and getting into trouble. Is documenting that you spoke to someone enough, or do you need them to write an entry in the notes?
I presume, thank you, Akash, this relates to when you're getting advice from somebody about a patient. First thing I would say is don't be worried about starting your foundation years. It's a really exciting time, and actually most of the time things don't go wrong. You are quite well protected by your colleagues, so please don't worry. And I think the purpose of me raising all of these things that might go wrong is so that you're aware of them, because being aware of them and what could flow, as I say, puts you in a much stronger position if it does. But on the whole, it doesn't. Do you write it in the notes when you've spoken to somebody? Yes, and I would write whom you spoke to and when. But at the end of the day, the purpose of these discussions is for patient care. It's not about defending yourself when something goes wrong. It's about what's best for the patient at the time. And it's simply, in my view, not practical to start saying, oh, we'll sign here, Dr. X, you've given me this advice, but can you sign to confirm that's your advice, or whatever it might be. So I think just a clear note in the records as to who you spoke to and when and what they said is fine. Not to say there's never an issue where one person says something happened and somebody else disagrees. Of course, these things do happen, but 99 times out of 100, they don't. And the best way, I think, to avoid those sort of disagreements anyway, is to summarise at the end of the discussion you've had with the colleague and say, right, so, you know, based on what we said, our plan is to do A, B and C. Is that right? Is that what you think? And assuming they confirm that is the plan, then simply documenting that should be fine.
I think the real take-home message of all of that particularly is to have that discussion at the end, because there are so many situations where I have seen documentation and then I've spoken to the person who's made that advice, i.e. directly from a registrar to a registrar, and they said, well, that's not exactly what I said. And whilst it's not really affected patient care, and it's actually just been a minor nuance of, yeah, no, I do think this is quite likely versus this is probable, it's not that likely. It does impact things to some degree. So I think it's really important to have that discussion and say, this is what I'm going to essentially be documenting as the advice you've given, to make sure that whatever points they've made to you have actually come across, because not only for documentation, not really for the defensive part, but actually predominantly for patient care. And because if you do confirm that plan with them, it really does make things safer.
Yeah, what I would add actually as well, Akash, is about when you start working for a new consultant. So as you rotate round through your placements, it's always worth checking with that particular consultant, especially if you're documenting things on ward rounds, etc., how they like things writing, because everybody has a different way they want things doing. And so for your first few days, just saying, you know, asking, is this okay? Is this the level of detail that you would expect me to write? And taking that constructive feedback at that early stage is always helpful as well.
And at the end of the day, given it's usually our name, which is right at the top of that ward round entry, we want you to do that. So any F1 out there, do not feel bad checking in with us about your documentation, about your discharge summary, about anything. Because at the end of the day, it's important, because we are the ones who are ultimately responsible. Well, actually, the consultant is ultimately responsible. But on the ward round, if it's me doing it, then technically I'm ultimately responsible. But also, it's really important for patient care that we get it right, because we want to make sure that they get the best level of care that they can. So that means make sure you interrupt me and tell me whether you think I'm making a mistake, because I'd rather be told and for us to get it right, rather than it's not about ego. And the other thing is to make sure that you check in, because ultimately working as a team rather than just working as some sort of dictatorship almost is going to be safer for the patient. The next question I think is aimed at Janhvi. What do you do when seniors tell you that you can't exception report?
Okay, yeah, we get asked this question quite a few times. And like Akash was saying earlier, you do have a guardian of safe working in every hospital. So it's definitely worth talking to them. It's not really something that should happen in theory, because it is part of our kind of legal rights according to our contract. So if there is a problem, and it's unlikely to be a problem, to be honest, and remember that if you raise it, not only is it good for you, but you're also making it okay for the rest of the team to exception report as well, which is great for everyone. So don't be afraid of speaking out about it, talking to your guardian of safe working. And obviously, if it's still an issue, like Dan was saying earlier, you can always contact your BMA kind of point of contact for your trust, and they can take it further for you, but it shouldn't be a problem.
Lovely. So we've just got one more question left. So you please do take the opportunity to ask as many questions as you can on the comments. If you don't get an opportunity, or you're rewatching this, as I know, perhaps 80% of the people watching these webinars are usually rewatching them. Even at that point, you can still comment, you can still email us. So info@mindthebleep.com. Please do let us know, because we love to answer your questions. But the last question is again aimed at the MDU. Sorry, Dr. Fryar, I feel like
that's fine. We always get lots of questions, don't worry.
Will the MDU help if the incident raised occurred before I was a member, if I'm a member when the issue is raised?
Normally not, no, it rather depends on exactly what the issue is, but it would be a little bit like, to use the best analogy we can, driving your car without insurance, crashing it, and then asking for the insurance company to pick up the issues. So, and we're not an insurance company, but in general terms, that's how it works. So we ask that you'll remember at the time of the incident. Lausanne's here and can tell you the price of membership. I don't think it's a huge amount of money, so I'm not here to do a sales pitch, but Lausanne might wish to, but I think pay the small amount. Is it £10 or something like that, Lausanne?
It's £10 for the year for a UK. Yeah.
To my mind, it'd be £10 well spent, hopefully. Hopefully it's £10 that you feel you wasted because you don't need us, but far rather be in that position than to give you an idea. GMC hearings cost, generally speaking, well north of £50,000. Criminal cases, a couple of 100,000 to defend. So hopefully you don't go there. Hopefully you never need us. But yeah, I think spend the money and then you haven't got that issue.
I definitely couldn't agree anymore. I mean, it's £10. You get a free gift as well.
You do. Yeah.
I would just add to that, if that's okay, Akash. So there is a thing, though, that if the incident happened while you were a member and then you left, you could come to us as well.
Mm-hmm.
Okay, and that's something called occurrence-based membership. Okay, so you either the incident had to happen while you were a member, right? Or, like I said, if you have now retired and you're not a member anymore, if the incident happened 10 years ago when you were a member, yes, you can still come to us.
Yeah.
Does that make sense?
Yeah, that makes absolute sense. And I think that's really important, because then you know that if you do leave, you're still covered if the incident did occur at that time. And so you should know that you definitely, even if you go the entire year and you don't find that an issue has been raised, at least you know if, and because as Dr. Fryar pointed out, these incidents get raised a long time after the actual issue occurred. I think a question related to that is that I have seen whilst surfing Reddit and various other sites, is if, so some people in FY1 take out both MDU and MPS membership, essentially trying to get both free gifts. And let's be honest, that happens.
Nothing wrong with that, guys.
Why would you not like free gift? Yeah. Mm-hmm.
One of the concerns that they raised on the forum was, what if they argue saying the other person should cover us, and therefore it reaches a situation where neither of them cover us?
Yeah, that shouldn't happen. We work very regularly with MPS and other indemnifiers, and yeah, we totally understand that people often choose to be members of both, and normally we'd split something 50-50 if there was another indemnifier involved. But yeah, it's not a situation where we say, well, if you've joined both, that's us out. That's not how we work.
I was sure that was the case. Just thought I would just put it out there. Lovely. I think that covers all
sorry,
of the...
one sec, Akash, we do have one more question on the Facebook comment. Sorry, it's just come up, asking, how do you suggest dealing with anxiety for the first few shifts? I'm going to quickly weigh in before if anyone else wants to say anything. I think a little bit of anxiety when you first start your job is probably a good thing, and it's healthy in a way. And I think the main thing to do is to remember that everyone starting F1 is anxious. All the doctors you're with have been through that. So everyone knows how anxiety provoking it is. And that's normal. I think the main thing for you to do to deal with that is speak to your colleagues. You'll have an induction where you'll meet all the other F1s, speak to everyone else. Don't be afraid to kind of sit in your corner and say, oh, I'm worried about this. Just voice it. Say, I'm worried that this is going to happen, or this might have happened, and what should I do about it? That's absolutely fine. Even speak to not just your peers, but also your seniors. You'll have F2s, SHOs, even the regs, they're all really friendly. If you're feeling some anxiety, speak to them. And we don't want to get to the point where you're feeling any sort of level of burnout or any mental health issues, like severe mental health issues. So obviously all the services we've talked about earlier today are available. But honestly, don't worry about it. I know this is a little bit of a scary talk at times, but it's actually nothing to worry about. And we're just giving you the information as a worst case scenario. and it's better to have it, but it's unlikely that any of this will happen to you. I don't know if anyone else wants to add anything.
I agree, absolutely. And I think the most important thing actually is to, accept you're going to be anxious, but this is an exciting time, and there'll be many times in your career that are slightly anxiety provoking, because you're always progressing and you'll often be doing things for the first time. But the most important thing is not to think that you're expected to know everything. You know, I remember starting my role as head of advisory at the MDU, which was 7+ years ago now, having gone from being in a senior position, but not this position, and thinking, well, I haven't suddenly developed a new level of knowledge overnight. I don't, I went to bed last night doing one thing, and today I'm doing something else. But the key is, asking for help, not being afraid to say, I just don't know, but I'll try and find out. And try to work out early on who the best people are to go to for help. As Janhvi said, colleagues, slightly senior colleagues are often really helpful, peers, but don't be afraid to ask. No one is surprised if you don't know the answers.
And that's true of all of us at all grades. So there's lots of times where I don't know the answer, and there's lots of times where I feel a bit anxious when I see somebody who's particularly unwell and feeling very unsure about what's going on. It's all about approaching things in a systematic way and discussing with your colleagues, because if you work together as a team and lean on each other for support, then it's better for the patient and it's better for you.
I was just going, sorry.
Yeah,
no, to cut you off. I was just going to add that if you are finding your anxiety a bit much and you want to talk about it with somebody, it's one of the top reasons that people access both our counselling and our peer support services, certainly in the top 5 for both of them, I think. So our counsellors and our peer support doctors are both used to helping people through that situation. So as Dr. Shah said, do seek out that support, not necessarily from our services, but there's a lot of support out there. So just I can just encourage you all to talk to somebody about it.
Lovely, thank you so much, everyone. I think that's all of the questions thus far. A couple of people have asked for kind of sign up links for the MDU, BMA. They are all in the comments. But otherwise, if you don't get them, if you don't see them in the comments, I will be sending out an email to all of you with the link to watch the video and also links to sign up to all of the services. And that means that the session is recorded and it will be available through Medal, also on YouTube, and also on Facebook Live. So there's lots and lots of different places where you can rewatch this webinar, so do not worry about that whatsoever. I want to take the opportunity to thank you so much to every single person from this amazing panel. You've answered so many questions. And honestly, the insight and advice you've given, I think 1 week before all of these F1s are starting, is absolutely amazing and absolutely essential. So I am sure this will be watched many, many times as the days go forward, getting closer and closer to the day all of them start. Are there any final take-home messages that all of you would like to share?
I think just enjoy it. I'm hoping that the person who's asking the anxiety question, it's more about anticipation than actually when the day comes that you'll find the anxiety isn't there, and it's more exciting than anything else. But the anticipation is the thing that sort of scares you. So enjoy it. That's what I say. It's great.
This is a wonderful profession to be part of, and you've got so many colleagues who are there in it with you. So yeah, absolutely, as Daniel said, enjoy it, seize the opportunities, and look forward to it. And yeah, this is the start of your careers. So fantastic, very exciting.
I'll say good luck, everyone. Enjoy it, as everybody else has said, and look after yourselves.
And definitely good luck from all of us as well at Mind the Bleep. So just to let you know about the upcoming sessions, next week on Tuesday, we've got a session about student loans on Tuesday at 8 PM. Just giving you a little bit of advice, because we know that all of you will soon have to repay your student loans. Apologies. And so we're going to use some advice and support in terms of how that works from an accountant who is also an FY1 and so understands it from both perspectives. We've also got another session on 2 sessions on Wednesday, one at 7 o'clock and one at 8 o'clock, one on interpreting imaging, so radiology for FY1s. And the other session is on top tips for essentially starting FY1 on the day that you start FY1, ready for when you start your placements from that Wednesday, 4th of August. So it will be Sarah and Ben who will be running that session, and I'm sure they're getting amazing slides and amazing discussions ready. So please do send again all of your questions in advance if you'd like to, if you're unable to watch the session, because we love to answer questions. Perfect, thank you so much. I will hand over back to Sarah to close the session.
Thank you very much, everyone, for the lovely session. And thank you, Akash, for inviting everyone for the session next week. I think we have answered all the questions. We have filled in the feedback form. We have posted all the links. So unless there's anything else anyone would like to add, I think we're ready to end the session.
Thank you. Bye.
Thanks for having us.
Thank you for having
Bye.
us.
Have a
Take
lovely
care. Bye.
Bye.